Hello. Hello.
Yes, hello.
Hello.
Hello, Dr. Cooper.
Hello.
I
Vamsi.
can hear you.
Hello.
Uday sir, I'm audible, Uday sir?
Yeah, I can hear you. Can you hear me?
Yeah, I can hear you.
Yeah.
Yes, yes, we can hear you.
I think I'll have to just check whether the slide I can share,
Yeah, you can share, sir.
because there's something else here. It's okay?
The slides
You can
are
start.
already on your background.
Okay.
Yes, sir. You can share your slides.
I'll just check it. Okay. 1 second. 1 minute. I'll just open that. I'll have to just check whether the slide I can share.
Yes, yes. I have. Today, sir, co-host, sir.
It's okay?
The slides are already on your background.
Okay. Yes, sir, you can just check it once. Shall I just check? I'll just check. Yeah.
Yes, yes. I have.
Is it visible? Is the slide visible?
Yes, sir, it's visible, sir.
Okay. So I'll stop sharing. Okay.
Yes. Yes.
Yeah.
Hi, good evening, everyone. This is Abhijit.
Yeah.
Hello,
Online.
Abhijit, sir.
Abhijit.
Hi,
Good evening.
hi, everyone. Thank you. Thank you for the opportunity to be here. Good evening. Hi. I'll share my screen as well
Hello, sir.
quickly so that, is my screen visible now?
Yeah.
Yeah, great.
Yes,
Okay.
sir.
And I just want to kind of hide these floating. How about now? Is it still visible?
Yeah. You'll have to make it
What?
slideshow. Yeah.
Okay.
Yeah. Yeah.
Great. Thank you. I'll stop sharing. Thank you.
Yeah.
Thanks.
I think.
Dr.
Chinsakar sir, good
Mr.
evening.
Hello, good evening to you as well. This is Shrikant Chinchalkar from Canada. So,
Oh, good evening, sir. Good evening.
Hi, sir.
Good evening, sir.
hello.
Hello, sir. Do you wish to check your slides too, or are you okay, sir?
I should be fine unless you want me to share my slides or see my slides. So, you have to allow me to share my slides, please.
Yeah.
You just go ahead, sir.
Okay, so you have disabled participant screen sharing, so you may have to give me an access. Yeah, I still don't have an access to share my slides.
So who is here from GHA? Is it Sumanashri or who is it?
Who's the host? Let me just check.
GHA is a host. Yeah. Hello.
I am the co-host. Wait, let me see if I can give.
Yeah, who's here from GHA? Hi, Sumanashri, are you there?
No, I can't make him a host. Actually, co-host
One
can.
second, just hold on.
Yes, sir. Good evening, sir.
Yeah, you can. Now you're a co-host. You can
Good
do it.
evening.
Yeah,
Yes,
just
yes, I
so
am
who's here?
allowed, sir, as a
Yeah.
co-host.
Yeah, what is your name? Sorry, can you have a name?
Dharmendra.
Dharmendra.
Okay, Dharmendra.
Yes.
Okay, yeah. Yeah, Dharmendra, in case if you're going anywhere, just make me the host and go, okay?
Okay, sir.
Okay, so I can I think it's visible to everyone if I'm not
Yeah,
mistaken.
yeah.
Yeah, yes.
Okay.
So, I think we are 7 now. Should we start or should we wait for a couple of more minutes to people to join in? So Dr. Uday Kumar sir is a senior orthopedic surgeon in Bangalore. He's very active in academics and presents a lot in all the conferences happening here and nationally.
Good
Those
evening,
of you don't
sir.
know him.
Good evening. Good evening.
Good evening, sir.
Mr. Palli, are you there? Palli Velu is our hospital, is a HOD of the physiotherapy. Sanjay Gandhi.
Good evening,
Good
sir.
evening.
Good evening to
Good
everyone.
evening.
He is a
Good evening.
PhD and MPT holder. So we'll start, sir. Are we all good to go?
Yeah, I think so. I think you can go ahead, Dr. Vamsi.
Yeah, good evening. Thank you and welcome you all to this webinar. So this is actually a pre-conference webinar or pre-cadaver workshop. As you all know, we are starting, we're doing a cadaver workshop on 22nd of August, mainly on the elbow. And Dr. Abhijit is one of our national faculty. So just before that, it's more like a course material webinar. So today's topic will be on terrible triad. So if you ask me why terrible triad, I think if you know terrible triad, if you understand terrible triad of the elbow, I think you know everything in the elbow. I think you learn the real head, you learn the corner, you learn the ligament, everything. And similarly, I think for the therapy point of view as well, you will be more after today's talk, you'll be able to understand better about how you rehabilitate a MCL injury, or repair or not repaired. I think Dr. Srikanth will be talking about that. So first speaker will be Dr. Abhijit, second will be Dr. Srikanth, and third will be Dr. Uday. He'll be presenting a case of terrible triad. So Dr. Abhijit, you can share your screen. Meanwhile, I'll just give a brief introduction about Abhijit. So Dr. Abhijit is a adjunct professor of hand surgery. He runs a hand and upper limb departments at Sayadri Hospital, Sancheti, and Jangir Hospital in Pune. Of course, he also travels across different cities to operate. He's currently a chief editor of Journal of Trauma and Orthopedic Surgery. He has more than 42 peer-reviewed publications, written 12 textbook chapters. He has given more than 80 national and international talks. He's also visiting professor to Shahid Beheshti University at Tehran, and is a founding president of Wrist Society in India. Of course, he's a member of various international societies such as SSH and our French Society. He's currently serving as a EC member of Maharashtra Orthopedic Association and APWA, as Asia Pacific Wrist Association. So Dr. Abhijit, you can go ahead with your talk on terrible triad. You'll be talking only about the surgical aspects and management.
Thank you. Thank you very much for that generous introduction, Vansi. Good evening, everyone. My name is Adhijit Vahegaonkar and I'm from Pune. We are having some very beautiful weather here, and the task of my talk today is to talk about the terrible triad. And as we go through the talk, we will try and understand different aspects of the injury, terminology, classification, pathoanatomy, and diagnosis, and then how to go about treating this. So I have no disclosures related to this talk. Elbow instability, elbow fractures are not very uncommon. They are very challenging. And this entity that is called as the terrible triad is a spectrum of injuries that involves the elbow and accounts for about 10% of all elbow trauma, and usually seen in sports-related injuries in the young, and because of a fall onto an outstretched hand in people who are above 50 years of age. And again, we need to understand that it is a spectrum of injuries, and elbow instability is the far end of the spectrum. Before we move on, we will try and understand the anatomy and concepts of stability, and then try to understand the etiopathoanatomy, the evaluation, classification, treatment, and then discuss a few cases. We know from our clinical anatomy that the distal humerus is very complex in its anatomy, especially the anterior aspect. There is a spool-shaped trochlea and a hemispherical capitulum, and the proximal ulna is also quite unique in its shape. More so the coronoid, which provides the anterior buttress and provides stability, and the sigmoid notch and the olecranon again, which kind of are very unique. There is a kind of an angulation, and the shape and the anatomy is very, very unique to this aspect of the body. The capsular ligamentous tissues that provide stability can be classified as those which are on the lateral aspect, on the medial aspect, and then also on the anterior aspect. The lateral aspect, we have the lateral collateral ligaments, which is comprised of three parts, and these are the annular ligament, the radial collateral ligament, the ulnar collateral ligament, and the lateral ulnar collateral ligament. And of these ligaments, the LUCL, the lateral ulnar collateral ligament, is perhaps the most important. This is a ligament which is kind of fan-shaped and goes on to insert onto the supinator crest. And this ligament is key. And when it is injured, we have an entity which is called as posterolateral rotatory instability, or PLRI. This is a schematic diagram which kind of shows you how these ligaments are all merged together. And it's a very complex kind of anatomy. The medial collateral ligament again has three parts: the anterior bundle, which is the strongest, the posterior bundle, which is a little thin, and the transverse bundle has perhaps the minimal or the least role in providing stability. And the medial collateral ligament arises from the antero-inferior medial epicondyle and goes on to insert onto the sublime tubercle. These are again schematic diagrams to show the different ligaments and the components of the ligaments, both on the lateral as well as the medial aspect. You have the supinator crest and the tubercle, and the sublime tubercle on the medial aspect. So before we understand instability, we need to understand the concept of stability. And the coronoid is a key stabilizer. And the commonest reason for residual instability after a coronoid fracture is to miss it, and perhaps even a failure to reconstruct properly, which will lead to persistent instability. The olecranon, interestingly, can be excised almost up to 50%, for example, with fractures and then yet the elbow will not be unstable. However, even a small fracture of the coronoid will result in instability. The radial head on the lateral aspect accounts for about 30% of valgus stability, and the medial collateral ligament on the medial aspect is the primary restraint for elbow stability. This diagram is a very important diagram. It comes from Morey's work, and he classified the stabilizers as primary stabilizers and secondary stabilizers. The primary stabilizers being the ulnar-humeral articulation, the lateral collateral ligament, and the ulnar collateral ligament, whereas the radial head, the joint capsule, and the muscles, the flexor pronator and the extensor muscles, are the secondary stabilizers. And there are several studies that have taken into account the biomechanics as well as the substance properties of the ligaments, and they have been described in literature, and we will not belabor too much on this today. So this is a slide that summarizes the different stabilities in different directions. The anteroposterior stability is a function of the articular surface of the humerus and the ulna. The valgus stability in the frontal plane is provided by the medial collateral ligament and the radial head, whereas varus stability in the frontal plane is provided by the radial collateral ligament, the olecranon, and the coronoid process. And this comes from this wonderful paper by Sean O'Driscoll and Kainan Ahn. This is the Mayo Clinic group that was published in Clinical Orthopedics in 1992. So with that brief introduction, let us now understand what is the cerebral triad that we are referring to. So there are three components to it. One is the dislocation of the elbow joint, the fracture of the coronoid, and of course, the fracture of the radial head. So all of these contribute to this entity, which is called as cerebral triad. And the mechanism of injury, as we discussed earlier on, is because of a fall onto an outstretched hand, which is the actual loading of the elbow. And there is relative elbow extension with a valgus force, and then some torque in supination, which will lead to the cerebral triad spectrum. So when we label this as cerebral triad, what is so terrible about it? It's basically that this injury is an extremely unstable pattern, and it's very challenging and very difficult to treat. Usually the fracture fragments are quite small, therefore they render themselves quite difficult to repair. And we all know from clinical experience that patients usually will not do well in terms of range of movement, or there may be complications such as heterotrophic ossification and so on and so forth. So residual instability, the stiffness, and more than that, the patient is unaware of the magnitude of the injury that is occurred at the elbow. They just see small fragments. They think that everything is fine, and then they should be able to go back to routine work. So we have already discussed about the lateral collateral ligament, the medial collateral ligament, and then these are the insertions onto the ulna. The proximal ulna is something that we need to discuss in a little bit of detail. So we have the anterior capsule that is attached along the screen line here. The brachialis is attached onto the blue elliptical circle here, whereas the anterior bundle of the medial collateral ligament is attached on this yellow circle, that's a sublime tubercle. And then we also have this cadaver dissection, which shows the proximity of the neurovascular bundle to different areas of the medial aspect of the elbow. We have the ulnar nerve posteriorly, whereas the median nerve and the brachial artery anteromedially, and these pass on beneath the flexor pronator mass. So you've got to be careful about the dissection on this side. The lateral aspect also is not without any risk, and we have the radial nerve and the posterior interosseous nerve. The posterior interosseous nerve, especially being in very close proximity to the radial neck, so you've got to be careful about it. And to orient you to the anatomy, we have the brachioradialis here with the extensor carpi radialis longus and the extensor carpi radialis brevis. So the mobile ward of Henry. Posteriorly, you have the biceps, and then which kind of goes in a swathe around the elbow. You have the origin of the extensor digitorum communis, the extensor carpi ulnaris, and the most posterior is, of course, the anconia. So we need to know this because we need to be in the correct plane to be able to have a good approach, not only to repairing the ligaments, perhaps the coronoid, but also for the radial head, either for fixation or for replacement. So the injury patterns include a posterior dislocation and a radial head fracture. And along with that, you have a coronoid fracture, which constitutes the terrible triad. And they may further also have subvariants such as transolecranon fracture dislocations, the anterior and the posterior transolecranon, which complicate the picture further. But these are very severe injuries, and we'll exclude them from today's discussion to keep this brief and succinct. Patient injury assessment is, of course, important in any injury or any case that comes to you. We need to evaluate the patient for any associated injuries. We need to take into account the mechanism of injury, soft tissue status. We need to also look at the operative timing to have optimum outcomes. Usually, earlier the better. Oops, I am a little. All right. Can I request someone from the Global Health Academy to please admit the people who are joining, and it's floating on my screen? So just a request, please.
Yes, sir. I have admitted, sir.
Okay. All right. Thank you so much. Thank you. So here is an injury pattern in a 47-year-old patient who had a trip and fell down the stairs. The X-rays may not be very ominous, but if you look at the CT scan, you can see that there's a great deal that is happening. The dislocation may not be very obvious here, but here you can see what is called as a perched pattern of the distal humerus onto the coronoid. So this is just to kind of highlight what happens in these injuries. We also need to take into account what kind of a fracture the radial head classification tells us, and we all know about the Mason's classification. There's a modified Mason classification where the type 4 has been added, where there's a fracture and dislocation. So this gives us a clue or a guideline whether this fracture can be fixed or it has to be replaced. There is no role for radial head excision today, and it's best either to preserve the native head or to replace it whenever possible. The coronoid fractures also are a very complex injury pattern, and very simplistically, Regan and Morey classified them as tip fractures. Type 2 fractures are which involve the body, but they are less than 50% of the articular surface, and type 3 are when it is more than 50% of the articular surface, and obviously they are very, very unstable fracture patterns. O'Driscoll went on to classify them further into tip fractures, anteromedial facet, base fractures, anterolateral facet fractures, and they kind of tell you whether there's going to be posteromedial rotatory instability or a posterolateral rotatory instability, and what should be the modality of fixation. More often than not, the guideline for fracture fixation in the terrible triad, which are usually small fragments, will involve some kind of a repair using a braided non-absorbable sutures, which could be transosseous sutures, which are demonstrated in the schematic diagram. So the sutures go through the capsule, and they include these fracture fragments, and then holes are made in the base of the olecranon, in the ulna, and they are brought out on the dorsal aspect of the proximal ulna. So this gives you a very, very robust kind of a repair rather than suture. Using suture anchors, we prefer this kind of a repair. And then you may make it easier by using an ACL pointing guide. The approach that you would take is basically determined by what is injured. For example, if only the radial head is fractured and there is a type 1 coronoid, and the radial head is a type 2 or 3 with a coronoid fracture, you would perhaps then go on to the lateral aspect, either fix or replace the radial head, and in the same window, you can then do your coronoid repair. The medial approach is usually required if you have to put a buttress plate or an anti-glide plate for a large fracture of the coronoid, or if you're required to transpose the ulnar or repair or reconstruct the medial collateral ligament. So usually the surgery starts with a lateral approach, and then you determine if you need a medial approach. Internal fixation usually involves 3 steps, wherein we repair the radial head, secure the radial head to the radial neck, and then obviously we need to be very, very careful to prevent any impingement of the hardware and put it in the safe quadrant. So the safe arc of the fixation is about 270 degrees of an angle that is subtended with the forearm in neutral rotation. And if the implants and the hardware is put in this quadrant, then it will not impinge with the forearm rotation. If the radial head is too comminuted and it is impossible to fix it, obviously we need to replace the radial head because excision will create a persistent valgus instability. And there are many options for replacement. We'll look at that in a while. The medial instability is always a big question mark, is very difficult, and is difficult. It's not only difficult to diagnose, but the decision making is a little tedious. If after fixation of the radial side or the lateral side, there is persistent medial instability, which is looked for by the river sign, you would then either repair or reconstruct the ligament depending upon the quality of the ligament, whether it is repairable or not. And we usually use suture anchors or tendon grafts, and then we perform a double reefing over the repaired ligament. So the usual protocol is to perform a coronoid fixation or repair of the anterior capsule, and then on the medial side, on the lateral side, you would fix or replace the radial head, repair the ACL, and then do a double reefing of the extensors over the repaired collateral ligament. On the medial aspect, you would again do a coronoid perhaps fixation or a capsular repair, a medial collateral ligament repair or reconstruction, and then reef the flexor pronator mass over the repaired ligament. So that's the usual kind of protocol for surgery. After having done all of this, if there is still any persistent instability, we bring in a hinge fixated to stabilize and start early range of movement. The surgical planning also includes giving thought to what the positioning of the patient should be. More often than not, we use the supine position because it gives you better access and visualization of the anterior aspect of the joint of the coronoid. And very, very seldom do we need a lateral positioning. The surgical approach includes a midline posterior approach if the patient is in the lateral position, but more often than not, the Cocker's position, Cocker's approach is required, and sometimes a Kaplan approach may also be used. Medially, we just use a curvilinear incision over the centered over the medial epicondyle and extending proximally for about 5 centimeters and distally for about 5 centimeters. We need to be careful about all the neurovascular structures. We already talked about that. The medial approach, again, can be a little tedious. We'll just talk about it. The Antonius and the ECU interval is usually used on the lateral side, and you have a direct approach to the radial head and the radial neck, as well as the coronoid through the window of the fractured radial head. We will not belabor too much on this, but suffice it to say that if you perform your dissection carefully, you stick to the lateral supracondylar ridge, centered onto the lateral epicondyle, and then you go distally, identify the posterior interosseous nerve and keep it out of harm's way. You get a very nice approach to the anterior aspect of the elbow through this approach. The medial approach can be of 2 types. One is the muscle splitting approach, and something called as over-the-top approach, where you elevate the entire flexor pronator mass, and then you can approach the anterior joint, the coronoid, as well as the medial collateral ligament. This approach is a little tedious because you have the neurovascular bundle as well as the ulnar nerve. So once you've identified and mobilized them, then it's quite a cinch to do these approaches. So we elevate a flap like so, which is the over-the-top approach, or we just split the muscles so that you can get a very nice approach to the sublime tubercle and the coronoid, so that you can use a plate to fix it. And this is usually an approach that is required for large fragments when you need to put in a plate or to repair it with these pull-out sutures. Using an ACL guide may make it easier. Our preferred approach is the medial approach for the coronoid if it's a large fragment, and the lateral approach if there is a very comminuted fracture that precludes approach from the medial side. So here's a case in point. This is a 38-year-old male who had a motor vehicle accident, and this was a high velocity accident wherein he fell down from his vehicle, and then he sustained this kind of an injury. It was reduced initially, and this is how we presented. You can see that there's a fracture of the coronoid. There is something going on with the radial head as well. We got some CT scans done, and this is the stress X-ray, wherein you can see the instability pattern. These are the CT scan images which show the injury. And this is wherein we went in because he had a medial collateral ligament injury also. And you can see the amount of soft tissue injury. There is a lot of hematoma, there is a lot of muscle tear and fibrosis and so on and so forth. So we bring in our suture anchors and we kind of create these sutures to pass. This is the ulnar which is brought anteriorly and protected. And you can see that we have also passed the sutures through the anterior capsule. To orient you, this is proximal, this is distal, this is the olecranon here. That is a medial epicondyle, and then this is the coronoid here. This here is the anterior capsule, and the suture anchor is here. And then we use these sutures, and we have passed them through the base of the coronoid and brought them onto the posterior aspect. And this is where we will pull on the sutures and tie the capsule down to the base of the coronoid. The lateral side, you can see the radial head fracture. And this was again, and there was also an injury to the lateral and the collateral ligament. I'm sorry, this video is not working, but this was just to show how the collateral ligament was peeled off from the proximal aspect of the ulna. Oops, this video is also not working. I'm sorry. There's something wrong with it. I apologize for that. Here is another patient who had a post-traumatic fracture dislocation, was reduced, was persistent instability. We went ahead and performed a ligament repair on the lateral aspect using transosseous sutures and a radial head replacement arthroplasty. This is another patient where you can see the common. So these are very small fragments, and they cannot be fixed with large plates. You need the small, very delicate, low-profile reconstruction plates, and then you also have the radial head replacement out there. Dr. Srikanth Chinsalkar will be talking about the rehabilitation. I won't belabor too much on this, but we need to strike a balance between preventing stiffness and also restoring stability. We usually begin with a posterior splint once the soft tissue edema has subsided. We do a guided rehabilitation with flexion first, active and passive, and then we gradually begin extension at around 3 weeks, and very, very gently in a protected hinge brace. So in summary, the terrible triad injuries can be seen as those that are not so terrible and those that are really terrible. The terrible triad injuries that are really difficult to treat are those that the patient is uncooperative, there is poor stability even after you have performed your repairs, there is associated injury, and they are challenging cases. However, if it is an isolated injury in a cooperative patient where you are able to accomplish stable repairs and a good arc of movement, you have been able to fix the coronoid properly, repair the ligaments. These are patients that will usually do well and will have good outcomes. So with that, I thank you for the opportunity to contribute here and be a part of this webinar. Thank you very much.
Thank you, Dr. Abhijit, sir.
I'll stop sharing my screen. Thank you.
Yeah. Dr. Abhijit, can we finish Dr. Srikanth's talk and then we'll come back for the questions?
Sure, yes, thank you.
So next, Mr. Srikanth Chinsalkar will be presenting his talk. So those of you who don't know, is a former senior therapist at Roth McFarlane Hand and Upper Limb Center. That's at Ontario, Canada. He has more than 50 years of clinical experience in treating the upper extremity conditions. That includes the 40 years of teaching and 30 years of research experience. He's worked as a guest lecturer at University of Manitoba, that's University of Toronto and Western University. He's conducted various courses and he's a recipient of many awards. To name a few, one is the Dr. Paul Brand Award of Excellence by the American Society of Hand Therapists, Award of Leadership by the Canadian Association of Occupational Therapists, Award of Excellence by Sisters of St. Joseph's Hospital, Best Educator by the Western University, and most awarded as a most outstanding prestigious alumni by the Nagpur University, that's in India, and a Lifetime Membership Award by the Canadian Society of Hand Therapists, an Award of Excellence in Teaching and Coaching. So recently he was also awarded Lifetime Achievement Award by the International Federation Society of Hand Therapists in 2019. So the fellowship which he was which is running before in Roth Institute, it's named after him. Now it's called Chinchalkar Hand Therapy Fellowship Program. So he's written many papers and many textbook chapters. We are quite fortunate to have him today for this lecture. Dr. Srikanth, you may proceed with your talk.
Thank you, Dr. Vamsi. And hello, Abhijit, Dr. Abhijit Vaigaonkar. And he has presented Terrible Triad in a very simplified manner, excellent manner. So thank you very much. It has made my presentation much more simpler. So looking at the elbow, normal elbow motion, we know that elbow joint is a hinge joint, and especially it is highly proprioceptive. And when we move our elbow joint from flexion to extension, extension to flexion, and in combination with forearm, we know that the recruitment of muscles definitely are dependent on the load demands placed on the elbow. So the elbow should move with precision and with complex articulation that we have that allows us to flex and extend at the same time rotate our forearm. So Dr. Vaigaonkar has given us a detailed information about Terrible Triad. Some of them are terrible, some of them are even more terrible in terms of not only the surgical management, but also from the therapeutic management as well. These patients definitely have a complex injury, and it is reported in the literature that they have a poor outcome. There are many complications reported in the literature, which includes joint instability. Patients usually end up having some amount of pain. Excuse me. Patients have post-traumatic arthrosis or arthritis. And in some situations, patients are likelihood of developing heterotopic ossificans. So it's important for the therapist to have full understanding of the injury. First of all, the anatomy and biomechanics of the elbow joint, but they also must know what has exactly been done for these patients following an injury. So history definitely will tell them which structures are involved. And in addition to that, it's important for them to understand all the surgical details that you have performed for this individual. So what is most important for us to know? How the skeletal fixation has been achieved, whether the patients have had radial head arthroplasty or reconstruction of some kind, or using plates and screws, and the location of plates and screws. And in addition to that, whether the ligamentous structures have been repaired. Most commonly, lateral ulnar collateral ligaments are repaired, and MCL may not be repaired, but that information needs to be given to the therapist. And in a situation where there is an excessive amount of instability or instability of the elbow joint, despite of lateral ulnar collateral ligament repair, you may choose to repair medial collateral ligamentous structures as well. And if the elbow joint is still unstable because of deficient strength of flexors and extensors, then definitely these patients require the external hinges as well. It's also important for the therapist to know whether there are any other associated procedures. But what is most important for these individuals is post-operative positioning. We know that the lateral ulnar collateral ligament, especially, is if it is deficient, then when you perform forearm supination and extension, the radial head has a tendency to translate posteriorly, giving you posterolateral rotatory instability. And we know that if the medial collateral ligament is deficient, then there is a medial opening, especially when forearm is pronated. So therefore, we have to consider all these, and we'll look at those situations as we go further. But in addition to that, it's important for the therapist to know what is permissible and stable arc of motion. And I must emphasize here that this can be determined intraoperatively by the surgeons, and this information must be shared with the therapist so that they are exactly managing these patients depending on what has been performed for these individuals. The other consideration, the therapist must know whether to limit elbow extension and how much. For example, if the MCL is repaired or as a tennis coronoid fixation, then obviously we do not want these patients to perform full extension, because the full extension is likely to produce translatory effect caused by the musculotendinous structure that being tight or incapable of producing that amount of motion. The translatory motion may cause disturbance of coronoid fixation that you have done. And secondarily, we must understand whether to limit elbow flexion and how much. So these are the important factors that must be taken into account by the surgeon, and this information must be shared by the surgeon with the therapist. And in addition to that, whether the patients have drop sign. Now, this drop sign was ignored for significant amount of time. When we looked at our simple and as well as complex elbow dislocation cases, we identified that the patients who have had presence of drop sign, they had poorer outcome in the sense that they had limited elbow extension, limited elbow flexion, and as a result, the elbow joint mobility was significantly reduced because of the presence of drop sign, and which persisted for lengthier periods of time. So our focus was to look at this and write up on the drop sign or drop sign management. And then since the surgeons see these patients on an ongoing basis, the surgeons must share the information about fracture healing with the therapist so that they can custom tailor these patients' treatment in accordance with fracture healing. But if these patients have heterotopic ossification formation, then that needs to be shared as well. However, heterotopic ossificans, I must emphasize here, is not because the therapists are too aggressive in mobilizing. These are old theories. Some patients are prone for producing heterotopic ossification. So besides that, the therapist must have a clearer understanding as to how the radial head is in relation to the capitulum. So in other words, the therapist must understand orientation of radial head superior or inferior to capitulum, and whether the patients have tilt sign. Nothing has been written on tilt sign. This is my unfinished paper at present, because we could not exactly talk about the tilt sign and the degree and amplitude of the tilt sign when this exists. Definitely, we know the drop sign, and it can be significantly measured. It can be very well or easily measured in terms of displacement that we see when patients have ulnohumeral instability or inferior instability. So just to sort of focus on tilt sign, if suppose you have a medial collateral ligament rupture, and you'll obviously see that the ulna will have a translatory orientation, and as a result, the radial head will be superior to capitulum, suggesting your medial collateral ligament deficiency, or even dynamic stabilizers insufficiency as well. And especially if you have a radial head inferior to capitulum, you may definitely see some greater amount of drop sign here, and you will definitely can conclude based on the orientation of radial head in relation to capitellum that there is a tendency for posterior lateral rotatory instability. In both these situations, you're likely to see two curvatures of the sigmoid notch, and that's what I was focusing on, the tilt sign. So even if there is a mild tilt sign, if you could possibly measure this tilting amount, then we could say definitely that this is caused by instability produced by the capsular pattern, the ligamentous pattern, as well as dynamic stabilizers patterns of instability. So it's important for the therapist to know why there is a radial head, why a radial head is inferior or superior to capitellum, whether it is caused by the deficiency of the static stabilizer, whether it is as a result of improper or inadequate positioning of the forearm in relation to the elbow joint, or whether it is produced by the deficiency of dynamic stabilizer strength. So these are all these factors that the therapist must understand, or whether it is caused by both these factors that is causing the tilt sign as well as drop sign as well. So that information is very important for the therapist, again, to custom tailor the management of these individuals who have had repair of a number of structures as well as restoration of elbow complex anatomy as well. So once we receive a referral, we look at the patient's symptoms, that what they experience. However, we look at their active assisted range of motion. We must keep in mind that following an injury or patients having such a terrible trauma, having reconstruction or repair of every structures, their muscles will not be able to generate the same amount of tension as they normally would otherwise if they did not have an injury. So initially, we'll look at active assisted range of motion. And if suppose patients have restrictions in terms of elbow extension, we will not assist extension because of possibility of distal humerus causing load on the repaired or stabilized coronoid processes. So initially, when we start these patients on treatment, we'll look at active assisted range of motion. And then as the muscles start to improve in terms of their capacity to generate tension, then we'll go on to looking at their active range of motion. However, these two is based on the reduction or after the reduction. Passive range of motion is withheld for quite some period of time. And this is, of course, will tell us the end feel of the soft tissue structures. In other words, the end feel is suggestive of resistance offered by the soft tissue following immobilization and following limited elbow motion. And this should be reserved for late phase of the rehab, elbow rehab, following terrible triad management. We also keep an account on level of pain, because sometimes the level of pain could be coming from various structures, especially elbow proprioceptive end organs, maybe the skin, and some other factors as well. However, we'll look at the location of pain. We'll identify whether it is on palpation, whether it is at rest, or whether it is with motion. And if patients have pain, we'll definitely recommend the surgeons to prescribe them with pain medication so that their rehab could progress on gradually on an ongoing basis. We also will keep an eye on clunking, clicks, or whether patients have apprehension with motion. And this is mainly to identify whether these things are present so that we can timely notify the surgeons if there is an existence of such things. The therapists tend to see these patients more frequently in our clinical setting as compared to the surgeons. And at my facility at Roth McFarlane Hand and Upper Limb Center, we work very closely hand in hand with the surgeons as well. Now, my main focus will be on therapeutic management of elbow fracture, but I needed to create sort of an understanding in the surgeon's mind as well as the therapist's mind as to what information is absolutely essential for us to have in order for us to manage these individuals and have the successful result. So our treatment is based on 3 phases. Phase 1 is starting from day 1 to 4 weeks. Keep in mind that at our facility, we do not immobilize the elbow joint. If the patients have had surgery yesterday, we'll start treating these patients the following day. So we start their treatment on day 1. However, we are very protective of as to what we should do because we get all this information sent to us by our referring surgeons, and therefore the treatment for these individuals is are custom tailored. It's better to have therapists on your team so that you can rely on them, you can guide them from time to time and help them custom tailor the treatment program for Terrible trial. And then phase 2 is from 4 to 8 weeks, and then phase 3 and 8 weeks onward. And this is based on fracture healing as well as tissue healing. So phase 1, post-operatively, will provide these patients with splint or splinting, and this is mainly for protection. If the patients have lateral ulnar collateral ligament deficient elbow, then forearm will be positioned in pronation. And if they have a medial collateral ligament deficient elbow, then forearm will be placed in supination. If they have both these structures traumatized or injured or repaired, or maybe even one of them are repaired, then we'll position the elbow in forearm neutral position. The elbow joint is positioned between 80 to 90 degrees during the day. However, we'll begin with extension splinting at night, and the forearm orientation will be in relation to the ligaments deficiency. So if the patient's lateral ulnar collateral ligament is repaired, then we'll keep the forearm in pronated position and elbow in extension. Now, keep in mind that if the coronoid process has been fixated, the amount of extension we place in the elbow joint will be based on the information that you have passed on to the therapist, which you have taken that intraoperatively. So positioning is very important. And because following trauma and following surgery, patients usually have significant amount of edema and pain. We'll use cold pads. Retrograde massage is, of course, reserved until the later periods. Manual edema mobilization techniques are reserved for later periods if patients have persistent swelling and persistent pain. However, we begin motion. The reason for us starting early motion is because we know that motion stimulates venous and lymphatic return, and it also minimizes pain because elbow proprioceptors are continuously stimulated with motion, and therefore they help in sort of retraining their motor and as well as sensory cortex, inhibiting the amount of pain information sent by the joint capsule or stratum fibrosum of the joint capsule. So our mobilization is based on ligamentous stability specific mobilization. As I mentioned, that we'll begin with active assisted motion, go on to active. But in case if these patients have an instability or they have a presence of drop sign, then we'll begin with overhead program. So here, of course, you can see the lateral ulnar collateral ligament repair in this situation. The forearm is kept in a pronated position. This lady had MCL tear. Her forearm is kept in a supinated position. And this lady has both medial as well as lateral ulnar collateral ligament injury. So she's using an overhead protocol, as you can see right here. So, however, if the MCL is repaired, will limit elbow extension. If the coronoid process has been fixated, will definitely limit elbow extension, especially because we don't want any adverse load placed on this fixation. And then we'll increase elbow extension by 10 degrees on a weekly basis, depending on the stability of the coronoid process and depending on the fixation of medial collateral ligamentous status as well. We will begin with active forearm rotation with elbow at 90 plus degrees. And this is mainly to maintain or retain forearm rotation, especially going into supination as well as pronation. Some of the mechanical studies that have been done at our facility has suggested that when the elbow is bent past 90 degrees, there is no load distribution on the repaired structures. Therefore, the forearm motion can be safely be performed with elbow past 90 degrees of positioning. What if the patients have presence of drop sign? So the management is somewhat different. Now let's focus on the drop sign. So Coonrad identified and coined this term as drop sign based on inferior dislocation of the elbow joint. So he identified that the ulno-humeral joint distance, if it is greater than 4 millimeter, patients have inferior subluxation of ulno-humeral articulation. And then there is another study that is very well done. They looked at the influence of gravity on unstable elbow, and they identified that gravity definitely influences inferior translation of ulna in relation to distal humerus. So in this situation, of course, there is a ligamentous insufficiency, there is a muscular insufficiency, and therefore the translation of ulna in relation to distal humerus is much greater. So it's important for us to understand what if patients have presence of drop sign, what will be the complications? The complications being if they have an inferior dislocation of ulna in relation to distal humerus, and when you attempt extension, there is a posterior impingement of ulno-humeral joint. And if they attempt elbow flexion, then there is an anterior impingement on the anterior side, and jointly together, patients will have an impingement and pain. And this is the main reason why patients will end up having elbow contractures, stiffness associated with pain. So having identified this with quite a number of our patients, we custom tailor or change their management based on what complications we identified, not only radiologically, but also looking at this animation that we got it created specifically to report on these impingement and pain. So looking at this, we can definitely custom tailor the treatment in terms of managing drop sign. So how do we reduce this drop sign? So here, of course, we have shown that both medial as well as the lateral ulnar collateral insufficient elbow, and especially there is a gravitational effect that causes your ulna to inferiorly sublux. So in that situation, in order to relocate your proximal ulna in relation to distal humerus, if we perform isometric exercises, it will help reducing the gap between the distal humerus and proximal ulna. So isometric exercises, when the patients are still in an elbow flexion plane, it can be done successfully. And then these patients are specifically trained to work on isometric exercises of elbow flexors as well as extensors. And secondarily, then they can perform active wrist and digital motion on a regular basis. But the best program for these patients to start with early control motion program is an overhead protocol, as you see in this particular case. So this is an overhead exercise program, and I have distributed an article that we wrote on Terrible Triad, and the entire management is described very well. So I hope everybody got a copy of this. If not, then please send me an email and I'll forward that to you, or you can send an email to Dr. Vamsi, and Vamsi will be able to distribute that article for you. So there are many articles that talk about the overhead exercise routine. And of course, in this situation, forearm position is definitely dependent on the ligamentous repair of MCL. And if suppose patient has an MCL deficient elbow, then forearm is positioned in supination. If they have a lateral ulnar collateral ligament deficiency, then we'll position the forearm in a pronated position. So we took few x-rays in order for us to look at the drop sign, and we identified that override protocol definitely reduced the gap between the distal humerus and proximal ulna with the number of exercises that we perform. So drop sign obviously must reduce spontaneously within first 2 to 6 weeks period of time. And if radiologically you see that there is a reduction of drop sign, then you can discontinue isometric and overhead exercises. And then you can initiate some progressive strengthening, starting off with light strengthening and gradually going on to a greater strengthening routine for these individuals. And at this stage, if patients still have limited elbow range of motion in terms of flexion and extension, then we can implement mobilization orthosis as necessary. So the take-home point here is strengthening exercises and application of mobilization orthosis should be used with caution in the presence of an unresolved drop sign. So unresolved drop sign means that there's still some amount of inferior instability of the ulnohumeral complex. The other consideration we take during the management of terrible triad or with any elbow injuries, that we definitely work on active shoulder, wrist, and finger range of motion. Because the elbow joint is a middle joint in the extremity. So if elbow joint is not moving appropriately or as much, the shoulder tends to become stiffer, especially when a critical focus is not placed on the shoulder joint. And also the wrist joint is also affected because we know that the muscles originate from medial as well as lateral epicondyle, and they're often traumatized as a result of terrible triad injuries. And then because these tendons of fingers are crossing over the wrist joint, primarily they originate from medial as well as lateral epicondyle, the digital motion is also affected. It's important that we keep on adjusting the night extension splint as the range of motion gains are made. Patients are given a well-outlined home program. And of course, we walk these individuals through the activities of daily living retraining, what they can do, what they cannot do, or how they should do some activities somewhat differently. So goal of our therapy is to increase arc of motion gradually. However, we must take caution to monitor signs of heterotopic ossification. So phase 2 management, because the patients have now progressed into fibroplasia period, the tissues are starting to become much more tighter. The soft tissue is losing its compliance in relation to the load applied. So at this stage, based on fracture healing, we can begin with grade 2 or a bit more aggressive mobilization. We can begin with passive range of motion exercises followed by active range of motion around 6 weeks mark. And again, that is based on fracture healing. At this stage, around 6 weeks marks and beyond, we can use low load dynamic splinting so that we can start regaining motion. And then we can begin with gradual strengthening after 6 weeks or around 8 weeks and onwards over time. We'll still continue to, monitor signs of inflammation and heterotopic ossification formation. I must say that you'll see early signs of HO formation around 6 weeks or a bit between or until 6 weeks, but beyond that, there's a lesser possibility of anybody developing heterotopic ossificans. Phase 3 management, of course, patients are now well into tissue remodeling phases. So as a result, we can be a bit more or a lot more aggressive in terms of joint mobilization, grade 3 and grade 4. We can be, however, we still are cautious in performing passive range of motion, but after passive range of motion, we must encourage patients to perform active range of motion so that we create a balancing act between elbow flexors, elbow extensors, pronators, supinators, wrist and digital flexors as well as extensors as well. At this stage, we'll begin with progressive strengthening. However, if patients are still having some limitation in terms of range of motion, which obviously they will, because we possibly could not gain full range of motion initially until this length of time. So therefore, these patients definitely will be the candidates for static progressive splinting. There are some homemade static progressive splints that we do, especially if these patients do not have coverage for commercially available or commercially made devices. And then patients will be placed on an endurance training program. So strengthening focuses on strengthening of all muscles. However, this strengthening should be in relation to structures that have been repaired. We know that the elbow extensors are only a couple of muscles, that is triceps and enconeus. Enconeus contribution to elbow extension is still questionable. So we can very well say that the elbow extensors is only triceps, and we, around this time, in order to retain or regain elbow extension and prevent flexion contractures, limiting elbow extension, we must strengthen triceps as well. So we encourage these patients to perform triceps strengthening twice as much as they are performing elbow flexion strengthening exercises. So we must focus on contracture process that is associated with elbow fracture dislocation, and more so with the terrible triad. We know that patients usually will have pain and swelling. So that is the first physiological factor that has an effect on elbow range of motion. But on top of that, we know that if the elbow joint is immobilized for a certain length of time, then it's likely to become very stiff. And why does it become stiff? Because the capsule and ligaments is shortening and thickening occurs over time. And Kevin Hildebrand, one of our ex-fellows at Hand and Upper Limb Center, who now works in Calgary, he identified that there is a hypermyofibroblastic activity that goes on the joint capsule. And he identified that if these joint capsule, which tends to thicken 100-fold following an injury, then it's quite likely that these patients have myofibroblastic activity. And secondarily, immobilization definitely will have a contribution to the intra-articular adhesion that are formed, and that will also limit elbow joint motion. And in addition to that, muscle spasm and adhesion of the muscles, musculotendinous structures to joint capsule will definitely limit range of motion. So it's important that we understand the contracture control and consider some splinting consideration. So looking at the limitation affecting elbow flexion is one, posterior joint capsular tightness, medial collateral ligament posterior band tightness, triceps contractures and adhesions, and triceps co-contraction as well, that will limit elbow flexion. So here, of course, videographically it's shown the posterior joint capsule, which if it is tight, then it will limit elbow flexion. And therefore, we need to focus on those. So there's quite a bit of work done in terms of splinting for these elbow injuries. One of my coworker, my staff, who wrote an article in 2006, he identified that elbow flexion hinge splint is effective if elbow flexion is less than 100 degrees. However, in such situations, if it is lesser than 100 degrees, then we must consider providing these patients with hinges, because hinges absorb compressive forces, and beyond 100 degrees of elbow flexion, the elbow flexion cuff is effective, and this helps in increasing a range of motion. So this is an elbow flexion cuff. It's a simple device that can be made by the therapist who are treating them, but the therapist can also make these devices in the clinic so that they have elbow hinges if the elbow range of motion is less than 100. So the structures that affect elbow extension is anterior joint capsular tightness. We know that the anterior band of medial collateral ligament is also a major factor that limits elbow extension. And the other structure that contributes to limitation in elbow extension is biceps brachioradialis contractures and adhesions and biceps co-contraction. Now, Morey mentioned that the functional elbow arc of motion is from 30 degrees to 130 degrees. In other words, he specified that if a person has gained 30 to 130 degrees arc of motion, functionally they can possibly do each and everything. However, looking at quite a number of our cases who had 30 degrees short of full extension, they were highly dissatisfied in terms of their elbow extension. So we looked at that biomechanically and identified that these patients definitely require specific attention. So we identified that these patients must be given 3-point pressure splinting, which is most beneficial in gaining terminal extension. And terminal extension, I mean, is that last 30 degrees of extension that is difficult to gain can be achieved by means of 3-point pressure splinting. So in northern part of in North America, we have an access to JAS splint, and this JAS, Joint Active System devices are introduced to the elbow patients as well as other patients by Banotti, and therefore this is called as the static progressive joint active system splint. These are commercially available here, especially to those individuals who have extended health coverage, but otherwise quite a number of our patients who do not have extended health, we custom fabricate these splints as well. And then there are other splints that are available to regain forearm pronation. This is a homemade dynamic ProSoup splint, and this is a JAS ProSoup splint. So this is a case of terrible triad. You had an injury, it's not as severe, but we have some other patients who have had external fixators, and in order to remain in my time frame, of course, I could not add those slides and videos as well. But if anybody is interested in knowing as to what we do if external fixators are used, I'll be delighted to share that information as well. However, there are some complications that are likely to arise, and this is one, instability, as I mentioned earlier, and this instability is treated by means of external fixator, and there is a different kind of a program that we use for patients who are in an external fixator. But we know that stiffness is very common, and according to Morey, we know that the stiffness could be intrinsic in nature, extrinsic in nature, or combined. So at times, depending on the situation or depending on the type of trauma in an individual, we are likelihood of seeing heterotopic ossificans. For example, here we see a big band of HO connecting to the forearm to the humerus. Here the person has ulna connecting to the distal humerus. This patient had radioulnar synostosis. So all these patients require HO excision, and then if the ligamentous structures are deficient, then they may repair the ligament or may go on to performing the reconstruction of the ligamentous structure. So this is one of our lady, excuse me. She had terrible triad, and you can see that she is limited in terms of her forearm rotation, and it could be very debilitating, especially if patients do not have rotation of the forearm. So intraoperatively, she had full range of motion in pronation and supination, and then we placed her in the recovery room. We placed her in elbow CPM, and we sort of placed her in about 60 degrees arc of motion initially, and then kept on increasing her arc of motion over time. And this is her elbow range of motion following the management. And this is her, excuse me, forearm rotation following HO radioulnar synostosis excision. So, come on. So in conclusion, it's important for us to understand that early positional splinting and mobilization are critical factors in regaining elbow motion, and corrective splinting and timely usage along with muscle strengthening definitely produces functional results. Excuse me, the key to success is communication with the surgeon and the therapist then having close communication with the surgeon will be able to custom tailor the treatment for your patients who have been operated for terrible triad injury. Thank you.
Thank you, Dr. Srikanth, for the elaborate lecture. So,
Thank you.
Now we will take some questions. Dr. Uday and Dr. Palni, do you have any questions for Dr. Abhijit and Dr. Srikanth?
Yeah, thank you, Dr. Vamsi. Thank you, Dr. Abhijit, and thank you, Dr. Srikanth, for your excellent lectures. And we have learned a lot from both of you, especially from the physiotherapy side. So, question to Dr. Abhijit, have you had instances where you have used an external fixator?
Yes, sir.
At any time?
Yes.
Particular
yes.
reason for using that?
The reason was that there was a severe muscle trauma, and the muscle, they are not repairable. Like you want to do a nice kind of a reefing. The ligament also was quite, although we used a tendon graft for the LUCL, we were not able to do a good repair for the MCL. So there was still some persistent medial instability, in which case we used a hinge external fixator.
And I don't want to further discuss, but Dr. Srikanth, a patient coming with an external fixator, I would like both of you to do you use a hinged external fixator, or you primarily use a basic fixator and then go on to a hinge? Question to both Abhijit and Dr. Srikanth.
Okay, I'll let Dr. Vaigavkar answer that question first, then we'll go on to answering what we do with patients.
So our preference is for a hinge external fixator. Of course, we don't have access to the very nice compass fixators that are available overseas, and the one described in Hotchkiss especially. But we do have some improvisations and locally made fabricated hinge fixators, wherein we try and find the center of rotation of the elbow, and then around that we build the construct with 2 Shan splints in the humerus and 2 of them in the ulna. And it's unfortunately only unilateral. We don't have bilateral splints that are available, fixators that are available abroad, or the compass fixators. So the ones that we have are locally fabricated, and these are the ones that we use.
So, at our facility, if a patient is fitted with an unhinged fixator for the elbow joint, there are certain considerations one must keep in mind. Because of the weight of that fixator and, of course, the position of the wrist joint has a tremendous tendency to fall into flexion and ulnar deviation. And secondary to that, posture, patients often have an imbalanced wrist extensors, wrist flexors, but at the same time, they have the ligamentous limitation as well. So we custom fabricate the splint in order to maintain the wrist position in relation to the forearm bones. That's 1. 2, we encourage patients to perform wrist extension and flexion, despite of them being in a fixed elbow fixator. And then we'll allow these patients to perform finger range of motion, because we want to increase excursion of the muscular tendinous structures at the level of the wrist as well as at the finger. And then we provide these patients with the posterior brace, posterior brace and of course a sling, in order to prevent any inferior translation of humeral head in relation to the glenoid structure, glenoid fossa, because that dependent position often causes inferior translation of glenohumeral joint. So subsequently, patients have significant amount of pain in their shoulder, and then they end up having an inability to move their shoulder. So now, of course, they have a stiff elbow, incapable shoulder, and limited wrist range of motion. So their whole entire extremity is compromised. And secondary to that, then they have a parascapular changes as well. So we start addressing these when these patients have been given a fixator. We position them in supine and ask them to perform shoulder abduction, internal, external rotation, so that we maintain the strength of the positional muscles of the shoulder. So we know the positional muscles of the shoulders include supraspinatus, infraspinatus, teres minor, and subscapularis. We must maintain the strength. We must maintain the orientation of humerus in relation to the glenoid fossa, so that there is no drop sign or inferior sulcus sign in their shoulder, as well as a result of severe amount of muscle atrophy. So that's the focus. And then we definitely know that when the fixator is taken off, they're obviously going to have limited elbow and forearm range of motion because of being fixed fixator. Of course, then we need to work on passive range of motion, active range of motion at a later stage. However, the best thing to do with these patients, if the muscles are intact and muscles are functioning, we can start working on these patients on day one, teaching these patients to perform isometric exercises so that we retain some amount of muscle capacity or capability, which will come in handy at a later stage when we are going on to passive and active range of motion program. Quite a number of our patients who do not have that significant instability of the elbow, they are given an hinge fixator, and with the hinge fixator, of course, they do not have full arc of motion in their elbow. However, they have some. So whatever arc of motion they have or is permitted by the hinge fixator, then we'll continue working with the elbow muscles in order to retain the muscular capacity, muscle strength, so that retention of muscle strength comes in handy at a later stage when they are on an aggressive mobilization. I shouldn't say aggressive, but systematic mobilization program after the fixator is off.
Thank you, Dr. Srikanth, for your explanation.
Yeah, good evening, doctors.
Yeah.
So my question to Dr. Srikanth,
Yes.
Sir, any specific reason is there? Because by pronating or supinating the forearm, we are taking care of whatever the ligament has been repaired. Any specific reason is there to keep it as a overhead and then trying to do the elbow mobilization? Can you put some light on that? Like what's the specific reason for that?
So if the person has a presence of drop sign is inferior elbow dislocation or subluxation, that means that there is an inferior translation of ulna in relation to the distal humerus. So obviously, in this situation, when these patients perform elbow extension and flexion, there is an impingement anteriorly and posteriorly, as I showed with one of my animation. So the importance of these patients performing overhead protocol is basically you are reducing the ulno-humeral gap. That's one, and by doing so, the elbow joint or your ulna is tracking well on distal humerus, allowing some amount of motion. So patients may not have full motion going into flexion or full motion going into extension. However, whatever arc of motion that you are allowing them to do in a supine position is definitely allowing your ulna tracking well on trochlea, giving you that arc of motion. And on top of that, patients will have a stable arc of motion because of them being in a supinated position. Especially this is mainly used when there is a gross elbow instability, despite of your repair of the ligamentous structures and repair of radial head, for example, or replacement of the radial head. So that is basically why we use overhead protocol.
Okay. Thank you, sir. And one more question. So when we can start the isometrics to prevent the drop sign? Because
So
you
you
told
can-
to,
Yeah, so all our patients are seen 1 day post-operatively.
okay.
So the surgeon has done surgery today, the patient is scheduled to come in therapy tomorrow. They're automatically given, routinely they're given an appointment. Of course, the OR nurse will call our hand therapy department, the secretary will look at whose schedule permits these patients to be seen. So the patient will be scheduled for that individual, and automatically that information either electronically transferred to the therapist about the elbow stability, elbow injury, elbow structural repairs, and so on. And so the therapist will have a complete idea of what, or surgeon may even call from the operating room saying that I have done this for this patient. And then we already have that information in our hands so that we can custom tailor the treatment. So the same very day, we'll provide these patients with the posterior elbow splint. They'll come out of big bulky that they have. We'll provide them with the posterior elbow splint. We'll position the forearm depending on the structures, and we'll educate these patients to start working on isometric exercises of their elbow on the day when we see these patients in the clinic.
Okay. Thank you, sir. Thank you very much.
Most welcome.
Yeah.
Any other question?
Dr. Vamsi, are you there? I think we have had a wonderful discussion, Dr. Abhijit and Dr. Srikanth. It has been a wonderful.
I mentioned here right now that I'll
Yeah.
be in India from November 2nd
Okay.
till
Hello.
March 7th, 2022. Hello?
Yeah. I think that will be quite a long time. You're going to be in India from November
Right.
to March. So it will be a wonderful time to learn many more things from you at that time.
Sure, I'll be delighted to travel and come down to your center, or if we want to organize something, on elbows or the wrist, I'll be delighted to be part of that as well.
Dr. Abhijit, do you have any questions for Dr. Srikanth?
No. I think
No.
Dr. Abhijit, I have a question. During surgery intra-op, after fixing the LUCM, you still have a drop sign on the C-arm. So what do you do after repairing the LUCM?
So that's exactly the point. If there is residual instability, obviously we have to look for the medial collateral ligament. That's one of the reasons why, and then go ahead and repair the medial collateral ligament. A lot of times we neglect the medial collateral ligament and we think that it will heal and scar down or probably not cause a problem. But if you do have a drop sign after a good lateral collateral ligament, you need to pay attention to the medial collateral and take that into consideration.
So from the therapy point of view, I must add here that when you have repair of both medial as well as lateral ulnar collateral ligamentous structures, these patients are bound to be a lot stiffer as compared to the others, if only lateral ulnar collateral ligament is repaired, but MCL is not repaired, for example. But however, the lateral ulnar collateral ligament repair definitely requires more attention, even though both these ligamentous structures are repaired. So in this situation, of course, these patients are more susceptible for having elbow contractures, especially. So therefore, based on repair of both these structures intraoperatively, it is very important for you to share that information with the therapist that intraoperative range of motion was, say, for example, 45 degrees to maybe 100 degrees or 90 degrees. So they can begin with 45 degrees short of full extension to 90 degrees in the first very week, and then gradually increase arc of motion by 10 degrees. Inflection, 15 degrees inflection, may go on to increment of 5 to 10 degrees in extension in order to prevent excessive amount of flexion contractions of these.
Yeah, I agree.
So, the reason I'm focusing on intraoperative range of motion is because earlier during my practice, and I worked very closely with Dr. Graham King, Ken Faber, Ruby Grewal. Back then, of course, Ruby was a medical student then when I was managing the hand therapy department. But I've had several discussions that you are right there in the operating room, you're seeing, fixating everything. So it's just a little bit of your time put in looking at what is the safe arc of motion permissible for these individuals, so that we can custom tailor the treatment rather than us treating these blindly, not knowing exactly how far the elbow should move following an injury, following repair.
Thank you so much, Dr. Srikanth. What I understand is that we have to work closely with therapists, share all the interoperative details so that they can work on it.
Right.
Thank you so much for your time. And Dr. Abhijit, thank you too for joining us. So hopefully when Dr. Srikanth comes, we can have more academic events happening here. So for now, thank you all. Good night. And special thanks to GHA for sponsoring this Zoom webinar. So have a good night. See you all for the elbow workshop happening on 22nd of August in Bangalore. Okay. Goodbye.
Thank you very much.
Great. Thank you.
Thank you.
Fantastic session.
Thank you, Abhijit. Thank you, Srikanth.
Thank you
Thank
so
you very
much.
much.
Thank you.
Thank you very much. Good night. Bye, everybody.
Thank you, Doctor.
Thank you.
Thank you.